Let's jump right into Chapter 366 and unpack a really fascinating, often misunderstood condition, mastocytosis. This is basically a story of a cellular malfunction, a situation where the exact cells designed to protect us become overactive and just multiply completely out of control. So let's decode the science behind this. To get our bearings, let's start with a clear definition. Mastocytosis is, at its core, an abnormal clonal buildup of mast cells. Now, you know mast cells are usually our key effector cells in allergic responses, right? But here, they expand pathologically and infiltrate various tissues. We're talking the skin, bone marrow, liver, spleen, and the gut. While it can pop up at any age, doctors most often diagnose it in infancy or young adulthood. And wrapping our heads around this rare condition is absolutely crucial, because honestly, decoding how these specific cells malfunction actually helps us unlock broader mysteries of the human immune system.
Here is our roadmap for this explainer. We'll quickly cover defining mastocytosis, the KIT D816V mutation, classifying the disease, symptoms and manifestations, diagnosis and BC findings, and, finally, therapeutic strategies.
Starting right off with Section 1, defining mastocytosis, a rare cellular accumulation.
Look at the sheer rarity of this condition. The prevalence of mastocytosis is estimated at just 1 in 10,000 people. And here's a kind of counterintuitive detail from the source text. Even though mast cells are literally the star players in allergies, the background rate of atopy, the genetic tendency to develop allergic diseases, is actually not increased in these patients compared to the general population. Plus, familial occurrence is extremely rare, so this isn't usually something passed down through generations. It's really a spontaneous acquired error. Which leads us right into Section 2, the KIT D816V mutation, or the stuck alarm. So if this isn't inherited, why on earth does this cellular accumulation happen? Well, the crucial malfunction happens right down at the genetic level. Mastocytosis is driven by a somatic gain-of-function mutation. You can think of this KIT D816V mutation as a biological alarm system that's just permanently stuck in the on position. Normally, the KIT gene gives instructions for making a receptor for stem cell factor, which regulates mast cell growth. But when this specific mutation hits, it endlessly produces mast cells, driving that clonal expansion. And, astonishingly, over 90% of patients carry this exact KIT D816V mutation.
Now, while the KIT mutation is the main culprit, the source material points out that it isn't always acting alone. In advanced forms of the disease, patients might carry additional genetic mutations, things like TET, SRSF2, ASLX1, and RUNX1. Taking a second to understand these extra genes brilliantly explains why some cases stay mild while others progress super aggressively. These secondary mutations are typically associated with other hematologic neoplastic disorders, which adds whole new layers of complexity and severity to the disease profile.
Moving on to Section 3, classifying the disease, from skin to systems. The clinical categorization strictly separates the disease into 2 primary buckets. On one side, we have cutaneous mastocytosis. We see this mostly in children. It's entirely limited to the skin, with absolutely no visceral involvement, and, thankfully, it often resolves spontaneously right before adolescence. On the other side, though, we have systemic mastocytosis, or SM. This one is way more common in adults, involves internal extracutaneous organs, most notably the bone marrow, and it always requires a tissue biopsy for a definitive diagnosis.
Systemic mastocytosis isn't just a single disease, it's actually broken down into a full spectrum of severity. Over 70% of adults have the indolent form, ISM, which thankfully comes with a normal life expectancy. But then we step up to smoldering SM, characterized by a much higher mast cell burden. Next up is SM-AHNMD, where the mastocytosis is actually coupled with a non-mast cell hematologic disease. At the highly severe end, we see aggressive systemic mastocytosis causing outright organ dysfunction. There's also an exceptionally rare solid tumor variant called mast cell sarcoma. And finally, mast cell leukemia, which the source notes is the rarest form and tragically invariably fatal at present.
Let's look at the real-world impact in Section 4, Symptoms and Manifestations, the impact of bioactive mediators.
Because mast cells act like tiny biological factories, releasing powerful bioactive substances like histamine and tryptase, patients experience a huge, sometimes completely chaotic array of symptoms. On the skin, they might get pruritus, severe flushing, and Darrier sign, which is basically urtication and redness when you stroke or traumatize a skin lesion. Inside the GI tract, these mediators can trigger severe acid hypersecretion, peptic ulcers, and diarrhea. For the bones, patients can suffer from pain due to marrow infiltration, plus a much higher risk of osteoporosis. Systemically, there's a very real risk of severe, life-threatening anaphylaxis with rapid vascular collapse. And the triggers for these massive mediator releases? It's often Hymenoptera stings, think bees and wasps, NSAIDs, alcohol, or literally just physical stress.
Now for Section 5, Diagnosis and BC Findings, Solving the Clinical Puzzle. So, with this massive, multi-system variety of symptoms, how do doctors actually pin down the diagnosis? Like, how do you definitively separate systemic mastocytosis from, say, a really severe allergic reaction or a complex gastrointestinal issue? Well, the diagnostic process is essentially a biological detective hunt. You can't just guess based on symptoms. You absolutely have to follow the clues to find highly specific pathological evidence to confirm it. Here's exactly how that puzzle gets solved in the pathology lab. Definitively diagnosing this in tissues means checking off specific criteria. You need the single major criterion, finding dense, multifocal infiltrates of more than 15 mast cells per aggregate in the bone marrow or other tissues. Then, you combine that major criterion with at least one minor criterion. That could be an abnormal spindle shape, aberrant CD25 or CD2 expression, detecting our familiar KIT D816V mutation, or a baseline serum tryptase level over 20 nanograms per milliliter. Alternatively, a doctor can also make the diagnosis just by finding 3 minor criteria, even if they don't see the major one.
Once the diagnosis is locked in, clinicians have to stage the systemic severity, and they do this using B and C findings. A really helpful way to remember this is to think of B findings as a heavy burden and C findings as catastrophic organ failure. B findings point to a high mast cell burden. Think bone marrow infiltration over 30% or a wildly high tryptase level over 200. But crucially, there's no actual organ failure yet. 2 or more of these gives you a diagnosis of smoldering SM. C findings, on the other hand, are grave. They prove severe end organ dysfunction and tissue destruction. We're talking falling blood cell counts, liver failure with ascites, or large areas of bone destruction known as osteolysis. Just one single C finding instantly pushes the diagnosis into aggressive systemic mastocytosis. Facing this spectrum, what can we do? Let's explore how modern medicine handles this in Section 6, Therapeutic Strategies, a Stepwise, Targeted Approach. Managing this condition relies heavily on a stepwise, symptom-directed approach. You always start at the foundation, basic H1 and H2 antihistamines to block mediator release, which really helps with the flushing and gastric acid. Step 2 involves mast cell stabilizers, like oral cromolyn sodium, to tackle GI issues like diarrhea and abdominal pain. Step 3 escalates to systemic treatments, corticosteroids and anti-IgE, specifically for severe recurrent anaphylaxis. But for those advanced variants we talked about, smoldering, aggressive, or leukemia, we have to scale all the way up to Step 4. That means using targeted cytoreductive therapies designed to actively reduce the mast cell burden itself. A huge takeaway from the source material regarding these advanced therapies is the role of targeted tyrosine kinase inhibitors. The drug avapritinib is now considered first-line therapy for advanced SM and even for refractory symptoms in indolent SM, mainly because it's incredibly effective at reducing that bone marrow mast cell burden. And why is this so significant? Because older generation drugs in this exact class, like imatinib, typically fail here. The highly specific nature of that D816V KIT mutation actually causes resistance to imatinib. It perfectly highlights why precision targeting is literally everything when treating this disease. All of this brilliantly illustrates the path forward, and it leaves us with a really fascinating question. As we continue to unlock the specific genetic drivers of rare diseases, could next-generation targeted therapies eventually silence the stuck alarm of mastocytosis entirely? I mean, could we one day turn off that D816V mutation for good? It is a thrilling prospect for the future of targeted precision medicine in hematologic disorders, and it perfectly wraps up our explainer of Chapter 366. Thanks for joining me on this deep dive. Keep questioning, and I'll see you next time.